Okay, so welcome to this talk on evaluation of the trauma patient from an orthopedic perspective. I'm Tom Lyon, and I have COVID right now, so I may be a little short-winded on this. Just a preview of the talk, go through the ABCs of trauma patient evaluation everyone needs to know, especially focus on airway and respiration, which I could use another one right now. Talk about circulatory failure, shock, hemorrhage, treatment, and then D&E, the assessment of disability and mental status, which is key in trauma patient evaluation. Also review a couple of the more pertinent scoring systems in polytrauma that are used and are certainly testable. And then I'll just go over briefly 6 orthopedic emergencies and their initial treatment. Again, I'll try to focus on the more salient testable material, and where needed, I've underlined this for emphasis. So airway is critical, obviously. From the beginning of med school, we learned the priority of A's and B's have to have an effective airway and respiration to maintain life. You need to maintain C-spine precautions and establish either an oral, nasal, or surgical airway before anything else happens. The lateral C-spine X-ray is actually no longer part of the ATLS protocol. A pelvis and a chest X-ray are, but not a C-spine. Questions sometimes in this area will try to goad you to take the bait, but don't do it. You might get an example where multiple patients arrive simultaneously. Triage nurse asks you to assess a patient with an obvious knee dislocation. She can't get a pulse on the extremity. Your next step should be, and they give you all these choices about checking the pulses, get an angiogram, this and that. The reality is perform a primary trauma survey first. Make sure they have an airway and a respiration before you try to save their extremity. These are gimme questions. They should be straightforward and easy ones to get, but this is how it goes in the trauma bait questions. Another case example, 45-year-old male brought in by EMS, status post a fall, collapsed scaffolding, GCS at 12, he's got these vital signs, head lacerations, an open left femur fracture. He's got his chest x-ray and his AP pelvis. Question, what injury is most likely to affect this patient's outcome, and what are the next steps? I think immediately most of us are drawn to the AP pelvis. That's obviously a life-threatening injury, as can be the subtroch femur. However, the answer is the chest x-ray. He has no lung markings on his right chest. Okay, this is consistent with a tension pneumothorax. There's some mediastinal shift to his left. Film on the right is after placement of his pigtail to reinflate that lung. So that happens first before we address anything. The next step is probably going to be a sheet on the pelvis, but that's step B. Another worker comes in from the same injury, age 34, GCF 15, blood pressure, vitals as shown, has an obvious fracture left femur, open fracture left humerus, and a clavicle fracture. Trauma chest x-ray, spot femur and humerus films as shown. What injury is most likely to affect this patient's outcome? Femur fracture, humerus fracture, or clavicle? This actually was adopted somewhat from a question on a trauma board's review question I got. And the answer is that it's probably the clavicle injury, because it's not just a clavicle injury. This is actually a scapulothoracic dissociation. And if you notice, the usually overlapped clavicle fracture is actually diastased here. And the line from the midline spinous process to the medial scapular border is markedly widened. These are horrible injuries with horrible consequences, and this will most likely be the most critical injury to affect this patient's outcome. So just beware when you get trauma patients. They give you that chest x-ray for a reason. They want you to look at it. So what about C, circulation? We move on. We want to identify the patient in shock. We need to understand what shock is. Essentially, poor tissue perfusion. When there's a oxygen debt, you have a lack of oxygenation to the tissue, you end up with anaerobic metabolism. Subsequently leads to buildup of lactic acid. And this is the definition of shock, poor tissue perfusion. Initially, we can measure this blood pressure, heart rate, O2 sat, and we will initially start to give crystalloid to this until we know what's going on. What level of shock is this? So when we see hypotension, we have to think about why. Why does someone have low blood pressure? And there are 5 most common reasons that we should be aware of. Hemorrhagic hypovolemic shock, bleeding. Obviously, cardiogenic shock, which could be an MI, it could be cardiac tamponade, some kind of a central region, an injury to the heart directly. Neurogenic shock, spinal cord, head injuries. Septic or anaphylactic shock, anything from a jellyfish to a insecticide poisoning, and then hypothermia. Let's go over these briefly. So hemorrhage is in 80% of people, and 80% of blunt trauma patients, the most common cause of hypotension. It's not everyone, but 80% of your blunt trauma patients are hypotensive because of hemorrhage. Cardiogenic shock, less common, but you can see this in elderly people. Someone has a heart attack, they have an MI, and then they fall down and break their hip. And so the etiology of this injury is actually cardiogenic. However, then they break their hip, and this may be leading to hemorrhage also. So you can get, non-exclusive injuries here. But something to keep in mind whenever an older person, especially, or someone with a heart history has hypotension, it may not be hemorrhage. And the answer for cardiogenic shock may not be loading them up with fluids the way you would someone with hemorrhage. Neurogenic shock, typically cervical or high thoracic spinal cord injuries. It results from a loss of the sympathetic tone, and this can be associated with bradyarrhythmias or ectopic beats, essentially an autonomic dysreflexia. If you see someone who's bradycardic and hypotensive, there's obviously a disconnect between the central nervous system and the cardiac system, and that's usually because of a spinal cord injury. Septic or anaphylactic shock, again, I've seen people with zero blood pressure after being exposed to a jellyfish. You can get this from all types of different anaphylactic exposures or chemical exposures, or septic exposures, someone who is in septic shock, certainly another very common cause. Hypothermia will usually present with its history and is easy to figure out from that. So assuming we have a source of hemorrhage, we're assuming it's a blunt trauma patient with hemorrhage, where can we bleed? What are the 5 sources of hemorrhage most commonly? This picture on the right just shows some of the retroperitoneal spaces, but you have to remember our entire blood volume is 5,000 mLs. That's a key number to know, and that can be lost in any of these 5 sources. One is external. You can bleed out completely, and certainly your EMS report can tell you, it looked like he lost a liter or 2 on the road. He's got a femur fracture now that's closed. He's probably lost another liter there, so that's someone who's going to be in advanced shock. So you get an assessment based on what's external, bloody dressings. Thoracic, you're going to see on the chest X-ray. You could easily bleed out into your chest, and that's why the chest X-ray is key. He's going to get a chest tube immediately if that's the case. Abdominal is traditionally done with a fast, focused assessment of sonography for trauma. That's done in the trauma bay, should be done in 5 minutes, and will tell you if there's blood actively or fluid in the abdomen. Extremities, this is where orthopedics is really asked to give their input. We know that closed femur fractures can bleed from 750 to 1,500 mLs each. You have bilateral femurs, you can lose half your blood, if not more. So we're talking about a lot of blood loss, and each extremity that you add can contribute more. You can also have extraperitoneal, and this includes retroperitoneal, perinephric, space of Retzius, any of these spaces shown here that are actually retroperitoneal, and or a combination of the above. You can bleed out your entirety into any of these 5 locations. So what's our initial treatment of hemorrhage? Obviously, direct pressure to bleeding wounds. I'm going to consider pelvic binders or sheets for any unstable pelvis. And I'm going to start crystalloid. It's probably been started in the field. If it's not, it's going to start in the ER. We're going to see what the response is to that. If they respond minimally, they're going to get a transfusion before we even know there's blood loss. If there's obviously a lot of blood loss, we're going to start to give blood, not crystalloid. And if there's a minimal response to packed blood cells, then we're going to instigate a mass transfusion protocol, which is essentially a 1-to-1-to-1 ratio of RBCs to platelets to plasma. So depending on what the patient's needs are and what your assessment is on first triage, you'd start with either crystalloid, blood, or mass transfusion protocol. This is the hemorrhage classification chart, and I think we all need to memorize this. I'll go through it in the next slide. Essentially, think of it as a rule of 15% increments. Your total blood volume, again, is 5,000 mLs. You need to know that, and you need to know that these 15% increments are what classify hemorrhage in class 1, 2, 3, or 4. So if you look at these numbers, you can break it down into two groups. You have your compensated shock, class 1 and 2, where the blood pressure is essentially maintained. It's a normal blood pressure. Your ventilatory rate may go up a bit, your heart rate may go up a bit, and your urine output might drop off, but your blood pressure essentially maintains the same. And this is up to 30% of blood loss. Right? You have 15 plus 15, 30% blood loss. Compensated shock, this is treated with crystalloid, and people will respond to that. They can make that blood volume back up. As you move past the rule of 15%, past 30%, when you move to class 3, and again, I outline here, this class 1, all your vitals are normal. You can lose up to this much blood. It's essentially donating a unit or two of blood, not a problem. But as you move on to uncompensated shock, which is the second half here, class 3 and 4, you've now lost at least 30% of your blood volume, okay, of your 5,000 mLs, and you now need a transfusion. And as you move towards class 4, or you're not sure if you're in 3 or 4, we're moving towards mass transfusion protocol. Your systolic blood pressure is decreased, your urine output drops right off, and your heart rate is now above 120. So these are some basic numbers you know about hemorrhage. Moving on to disability, it's all about the Glasgow-Coma score. Simple stuff we all learn in med school. 3 assessments. You start from the eyes at the top, move down to the mouth, and then down to the motor. 4, 5, 6. There are 4 levels of eyes, 5 levels of mouth, 6 levels of motor. Add them all up. You get 15 if you're A&O times 3. If you get a level of 3, it's basically you're dead because you have none of any of the above. And it's important to note that the GCS is actually the single best predictor of mortality on any patient who arrives in the ER. And so it really says a lot just in and of itself. Some other important scoring systems for polytraumatic patients. I don't know that all these are really testable, but I think a few of them are. I'll go over briefly the RTS, Revised Trauma Score, the AIS, Abbreviated Injury Scale, the ISS, Injury Severity Score, and the NIS, the New Injury Severity Score. The last 2 of these both derive from the Abbreviated Injury Scale, so I think it's important to understand the relationship between these 3. The RTS a bit less. The RTS essentially is something used in field trauma. It's based on GCS, blood pressure, and respiratory rate. You don't need to know these numbers, but if the RTS is raised, it's a question that's based on that Glasgow-Coma score, #1 predictor of mortality in the ER, the blood pressure, and the respiratory rate. You get a score of 4 or less, it's been proposed that those patients should go to a level 1 trauma center. So that's the RTS. More importantly, the AIS, the Abbreviated Injury Scale, something that feeds into, again, the ISS and the NISS scoring systems. It breaks the body down into 9 anatomical regions as shown, and then it assigns 6 degrees of injury as shown here. And these are, somewhat debatable what a severe, life-threatening, but probably survivable injury is versus a severe, critical, survival uncertain injury is. But this is the system that has the most literature citations on it, and they build into the ISS. So the ISS is the Injury Severity Scale, and it comprises these 9 anatomic regions. It compresses the 9 anatomic regions of the AIS into 6. So these are the 6 that are left: head, neck, face, thorax, abdomen, extremities, and external. What it does then is it takes the 3 most severely injured body regions, right? Your worst extremity injury, your worst thorax injury, your worst head injury, whatever it is, and it sums up the squares of those 3 regions to get a score. So an ISS greater than 15 total is considered a major trauma in general and has a mortality rate of about 10%, and it goes up from there. The problem you could see pretty clearly from this is that it doesn't account for multiple high-grade injuries in the same region. So for example, if you have bilateral femur fractures, scores the same as a single femur fracture, and bilateral femur fractures and a humerus fracture still scores the same as a single femur fracture. So there's a problem with that. And that's where we come into the new ISS. And the new injury severity score is similar to the ISS, but it takes the 3 highest scoring injuries, not the 3 scores from the highest areas. And regardless whether they're in the same anatomic region or not. So if you had femurs bilaterally, you might get 9 for this and 9 for that. You're already in 18. You're already in major trauma, whether or not there are any other injuries involved. So here again, this is patient with bilateral femurs. The NISS would account for the fact that there are multiple injuries in the same region. That's the distinction that's important to know between NISS and ISS. And the NISS has been shown to be more predictive of mortality and morbidity than ISS. So briefly, 6 orthopedic emergencies that we should know something about. Go over these briefly. Open fractures. Fractures or dislocations with either vascular, neurologic, skin damage, or the threat to the same. Compartment syndrome. Hemodynamically unstable pelvic fractures. Polytrauma, multiple long bone fractures, or spine injury with neurologic deficit or cauda equina. These are 6 injuries that are going to require immediate orthopedic care in an emergency room or shortly thereafter. So I'll go through these briefly. Open fractures, we're all familiar with the Gustio classification system. It's something we still need to know. It's always testable material. I think some of the key points are understanding the difference between a 3B and a 3A, right? We remember 3B actually requires free tissue flap or rotational flap coverage. Okay, it's not local coverage, it's rotational flap coverage. So once you get to that point where you're needing to rotate tissues to cover something, it's a 3B, okay? 3C, there's arterial damage that actually requires repair. So similar to actually requiring a flap, this one actually requires vascular repair. It's not that you've lost one of your 3 vessels to the foot, and that's been shown in an angiogram. It's that you've lost enough of the vessels to your foot that a vascular surgeon needs to come in and do a repair that gets it to a 3C. The rest of the distinctions are self-evident. Open fractures are initial treatment. You always have to consider, if we're trying to rule out an open joint, to do a saline load test or a CT scan, which has been shown to be more accurate in ruling out open joints. Tetanus treatment depends on vaccination history and the injury severity. For grade 1 injuries, if there's a question of the history of vaccination or 10 years since the last, they get the vaccine. For grade 2 and 3, if there's a question of the history of if there's a question of their history, they're going to get the vaccine and immune globulin, or if it's less than 5 years since the last, then vaccine only. Time until IV antibiotics greater than 60 minutes has been associated with increased infection. This number has moved back and forth, but currently 60 minutes, there is data showing increased infection rates with delay of initial IV antibiotics. In contraversion to this, the time until OR debridement, up to 24 hours, has not been associated with increased infection. And there are not particularly randomized prospective studies demonstrating this, but prospective cohorts looking back up to 24 hours has not been associated with increased infection. There's also been no advantage shown to high pressure lavage versus low, and there's been no advantage shown to adding antibiotics to any irrigation. Fracture dislocations with injury to vascular, neurologic, or skin integrity. Vascular injuries, we always have to consider occult injuries and knee dislocations. These are often self-reducing injuries that happen in the field. This can be missed about 50% of the time. And they can be low energy injuries in morbidly obese people. You can rule these out with serial ABIs, looking for an ABI greater than 0.9, and normal biphasic pulses. If there's any question of these pulses or of the ABIs, and a CT angio is the rational alternative. Neurologic injuries, are going to consider the sciatic nerve injury and any unreduced hip dislocations, and certainly an incidence of maybe 10 or 20% of AVN and femoral heads when left unreduced for prolonged periods of time. Skin integrity, we always have to consider with unreduced fracture dislocation events, but especially in posterior calcaneal fractures. As shown here, this is a typical kind of test question or some type of a subtalar dislocation where the skin is blanched, and the answer is to get to the OR before it becomes an open fracture. Compartment syndrome, we're all familiar with. Need to maintain a high index of suspicion. Pain with passive stretch is the most sensitive finding, or you can grab the large toe and just kind of move it up and down and ask if that causes pain. And we're always remembering that 30 millimeter gradient we want to maintain between diastolic blood pressure and compartment pressure. If you can maintain that gradient, it has been shown to be zero incidence of injury to the muscle. So the technique of measuring a compartment becomes important. You need to be locally within 5 centimeters of that fracture site if there is one. And in anesthetized patients, you need to remember that the anesthesia may have brought their diastolic blood pressure down. So that needs to be corrected. It's also been shown that a single lateral approach can be as effective as dual incisions done correctly. And then what about hemodynamically unstable pelvises? So the unstable pelvis fracture is traditionally going to get binder or sheets immediately. This binder is centered over the trochanters, not the iliac crest. Right? You're really using the femoral heads to push this together as a clamp. You know, place this prior to x-rays, and there's minimal concern of overcompression, although you obviously can generate a lot of torque with these devices, so you don't want to go too far with this. This pelvis, once clamped down, looks like that, and there's the x-ray showing the same type of reduction. Again, this is placed down below the iliac crest. Hemodynamically unstable pelvises, again, come in two types: your external rotation or open book pattern. It's typically an APC3 type injury. These have the largest blood loss by far and the highest mortality by far. 90% of this bleeding is from the venous plexus in the back. And this is your typical open book injury. And you can see fluoroscopically here is closing down when the binder or sheet comes on there. And the contradiction to this is the lateral compression injury that typically fall on the side or hit from the side. Patients will most often die from head injuries with this type of pattern. And they also are the ones who may have missed rectal, vaginal, or genitourinary lacerations, as the pubic fractures can rupture internal viscera. And this 2.5 centimeters of diastasis that we learn about is a key marker based on Marv Tile's anatomic studies showing the necessity to disrupt the pelvic floor, the sacrotuberous and sacrospinous ligaments, when you diastase more than 2.5 centimeters. So if you've gone more than 2.5 centimeters, you've gone a lot further in the back. You've torn a lot of these ligaments. You've probably torn a lot of the venous plexus in the back too. What about polytrauma, multiple orthopedic injuries? The unstabilized fractures can be a significant source of bleeding. Right, each femur 750 to 1500 cc's of blood, tibias 300 to 750. You can add them up pretty quickly and get yourself into class 3 hemorrhage. This is painful injuries. They require respiratory suppressing narcotics, which is not good. And these injuries incite a somewhat cytokine storm that can lead to ARDS or SIRS. In addition, just immobilization and traction will lead to recumbency, DVTs, and poor respiration. So obviously the first choice is early definitive fixation, but as patients become sicker, we have to be aware that there's a point where damage control orthopedics is a more rational choice. And this typically involves external fixation of long bones and may be indicated in patients who are hemodynamically unstable, either class 3 or 4 hemorrhage, which is not being compensated for, patients who are cold or coagulopathic, maybe platelets less than 50,000, people who are either metabolic or respiratory acidosis, less than 7.25. People who have a buildup of lactic acid, lactate, or a base excess greater than 4. And you can have a whole talk on damage control orthopedics, but they'll generally give you a picture of low urine output. They're going to put them in class 3 or 4 kind of hemorrhage and shock. It's not being compensated for, and the answer is to either wait and delay or do damage control orthopedics at this point. Lastly, spinal cord injury with worsening neurodeficits. We're all aware of called Aquinas syndrome. It's kind of acute disc herniation with bilateral leg pain, bowel and bladder dysfunction, and this typical kind of neurogenic bladder where you have urinary retention and subsequent overflow. It's classically a saddle anesthesia, and this needs to be urgently decompressed really within 24 to 48 hours. You see this with thoracolumbar fracture, same kind of emergency to any thoracolumbar fracture with progressive neurologic deficit. So that's essentially that for the orthopedic emergencies. Thank you very much.